Joining us for Rory A. Marshall's webinar on how paramedics care for and support survivors of intimate partner violence, a unique opportunity to activate an underutilized resource. I am simply kind of like the host for today. I'm here to introduce Rory and to also provide some support around the Q&A if you'd like that. I'm Dr. Sarah Yursich. I am an early career researcher with AVA, and I am also the Associate Director of the FREDA Center. Before we dive in, I did want to quickly mention the session is being recorded. So please do leave your cameras off during the session, and then you're welcome to turn them on toward the Q&A portion of the webinar. To begin, I'd like to acknowledge that the AVA Health Research Training Platform respectfully recognizes and acknowledges the relationship that the First Nations, Inuit, and Métis across Canada have with the land all Canadians live on and enjoy. We encourage all Canadians and visitors to these lands to learn about and regularly acknowledge the historic and current relationship that exists between the unceded land on which we live and work and the First Nations, Inuit, and Métis peoples. We also encourage all Canadians to consider how they can personally contribute to Canada's reconciliation with Indigenous people. And I'd also like to quickly acknowledge that we here at the FREDA Center live, work, and play, I guess you could say, on the lands of the Coast Salish peoples, including the Tsleil-Waututh, Coquitlam, Squamish, and Musqueam nations. Now, before we dive in, just a little bit about Rory A. Marshall, our speaker. He is a subject matter expert in both intimate partner violence and paramedicine. Excuse me for all the coughing, this just started. Marshall is a PhD candidate in the Faculty of Health and Social Development at the University of British Columbia, Okanagan. He completed his MSc in Biomedical Sciences at the University of Saskatchewan and his BA at Vancouver Island University. Clinically, Marshall practices as a paramedic for the Alberta Health Services, Emergency Medical Services, and British Columbia Emergency Health Services. And I'll put his full bio in the chat, but I don't want to waste any more time. So Rory, please go ahead.
Awesome. Thank you for the introduction, Sarah, and thank you everybody for attending today. I'm really excited for the opportunity to talk about some of the work that my amazing team and I have been able to do and chat through all things kind of paramedics and intimate partner violence. So thank you for taking time out of your day, and hopefully this is a very useful and informative session with some good discussion at the end. So just before we get into anything, I just want to say that today we are going to be talking about intimate partner violence, which can be a very sensitive topic. This presentation has been designed to be very low stimulation. There's nothing shock or wow factor built in. All the images are stock images or staged images. So there's no real images here, but just before we get started, that's going to be what we're going over today. So without any further ado, I want you to imagine that you're a paramedic hurtling down the road to an emergency, and that your adrenaline's pumping and you have no idea what's going to be outside those doors when you get there, and your mind's just racing as the lights are going and the siren's going and it's all happening at once. And you're going and you're thinking, you're like, is it going to be a heart attack? Or maybe is it going to be a car accident? Or is it going to be a front page of the news Chicago fire style burning building event? Whatever is it going to be, and what's that going to look like? But instead, when you arrive, you land here. And when you go inside, this is what you see. And now as a paramedic, you're faced with this situation involving intimate partner violence. What do you do? And that what do you do piece is really what my team and I are looking at and have been researching and are all about, and kind of what we're going to go over today. That intersection between paramedicine or emergency medical services and intimate partner violence. So a quick outline just to orient you to how we're going to walk through things today. First, I'll get over some objectives of what we're going to talk about and what I hope you get to take away from today's presentation. Then we'll get into some background just about the project and the subject area. Then some methods in the ongoing research that we're using to move the ball forward in this area. Some of our preliminary results and what we've done so far. Some discussion around that. some actionable items, so things that if you're working with paramedics or are a paramedic or know someone that's being serviced by paramedics that you could bring up and start using today, and some kind of longer term things, and then some key points. So our objectives. First one is to understand the current state of paramedicine and intimate partner violence in Canada. And then our second one is to understand how paramedics can be utilized to support survivors of intimate partner violence. So for some background here, intimate partner violence, you'll see it written out in my presentation as IPV quite consistently. So this is commonly synonymous with partner abuse, spousal violence, all those terms. And this, for the definition we're going to use today, is intimate partner violence is the physical, psychological, sexual, or stalking-like behaviors to exert power and control over a current or former intimate partner. Now, intimate partner violence is predominantly against women, but is also extremely prevalent in vulnerable populations, so anyone at risk of being marginalized in any of those ways. Now, thinking through, our lifetime prevalence among women is 30%, so 3 out of 10, and our 12-month prevalence among women is 10%. Now, something that I think is really, really important to distinguish here is these are reported numbers. So depending on how they collect that information and what it all looks like, the prevalence is likely much higher. So this already kind of astronomically devastating problem is likely worse than it appears. So if we think about kind of the effects from intimate partner violence, there's a ton of things and a ton of kind of the issue categories you put this in. Intimate partner violence has historically been considered a criminal issue, and it is, and there's a ton of aspects around that. There's also the social aspects as relating to socioeconomics, but the big piece we're going to think about today and kind of where my area focuses on is health and well-being. And if we think about this, intimate partner violence has been known to affect every bodily system. So we're talking about kind of the nervous system, the GI system, reproductive system, all these different pieces can be affected by all types of violence, and that's fairly well documented. And these effects can be acute, meaning they're very short term. Like if I fell and broke my arm, that would be an acute injury. Whereas if I developed arthritis in my hand, that would be a chronic situation. So the effects can be acute and chronic. Now, thinking more about health, we're going to talk about healthcare. And healthcare access is a huge piece here. But before we get to that, healthcare is this really reactive system. And I always like to highlight that proactive approaches to prevent violence would probably, if they were done effectively, have better long-term outcomes than any kind of reactive approach. That's that kind of public health, a pound of or an ounce of prevention is worth a pound of cure saying. But the healthcare system is what we work in, and that's this very reactive system. And so that's involving kind of our hospitals, our emergency departments, or EDs, urgent cares, all those different pieces. Now, often superseding those and forgotten in healthcare are paramedics. So shifting gears and thinking about paramedics, you'll hear a bunch of different terms come up. I try and be consistent. I'm just going to use paramedics today, but emergency medical services is a really common term in the US, and this encompasses paramedics and EMTs, advanced EMTs, all those different pieces. But I'll just use the term paramedics to refer to this whole group today. So paramedics and paramedicine we think of as this mobile services that are half healthcare and half emergency service. And this is a really unique intersection because if we think of healthcare with hospitals and nurses and x-ray techs and doctors and that kind of system of referrals and all these different pieces, paramedics are involved in there with kind of a foot in that pond, and then also emergency services, so fire, police, ambulance, with a foot in that pond of that kind of real world live on the street application. And moving forward from that, paramedics are in a really unique position. So in that particular positioning between healthcare and emergency services, we have this stance that we're invited into people's homes. And it's really important to pause for a minute here and just think about that. So if we think about everybody's home other than yours that you've been invited into in, let's say, the last week, two homes maybe for me, a couple of friends visits, whereas in an average day, paramedics can be in 14 different homes, playing an appearance in 14 different lives, and just seeing that unique insight into things that is otherwise lost to the rest of healthcare. And one example I like to make here, I had a patient we saw, she had a bunch of mobility aids in her home, non-violence related, just she had a bunch of mobility aids, and one of them to help her get in and out of the bathroom was cracked. And so she was frequently having falls. When she would go to the hospital, they would ask her if she had mobility aids at home. She would say yes, them not seeing that this cracked aid is causing her falls and the cycle goes back in. Whereas when we went in, saw that, and then went to the hospital and showed she does have them, but this one needs replacing, and then she didn't have those experiences. So just those little things where there's this opportunity when you have that extra level of insight as paramedics. And the other thing is that first point of contact. So paramedics do a really good job at positioning people to enter the healthcare system, or I shouldn't say do a really good job, I say impact how people enter the healthcare system. So if we're really good in our recognition and diagnostics and treatment and moving someone through that's having a heart attack, and it's very obvious, that might get recognized really quickly and they go in with that stance. Whereas if we think, oh, maybe this is something else, they might be positioned to enter that healthcare system from a different footing. So it's that first point of contact that shapes the rest. Now, in Canada, the current state of paramedicine is rapidly evolving and rapidly changing. And before I get into some of my rah-rah, it's not the best, it's really evolving right now, and it's grown so much in the last 5 years. But there's still a lot of room for improvement, and there's ongoing work to improve it. But right now, this is where we're at. So paramedicine nationally is governed by the Paramedic Association of Canada, and under their most up-to-date guidance, there are no educational standards around intimate partner violence, and there are standards around kind of child abuse, partner, elder abuse, abuse of persons with disabilities, but no competencies around partner abuse. So then there's no educational standard, which then segues into no training standard, which then segues in to no clinical practice guidelines. So we have this ongoing challenge where we're missing this piece, and there's not even a standard right now for paramedics to document when intimate partner violence occurs. And this can leave paramedics in a bit of a no man's land when they encounter these situations, because then you're looking at people relying on different aspects of their lives outside of paramedicine to navigate these situations. And that can present in this kind of scenario I'll play out for you next. So if we think about paramedicine, conveyance and non-conveyance are two big options. Conveyance meaning transport to a hospital or a healthcare facility. Non-conveyance meaning that person's choosing to stay at home. And there are a few more pathways, but these are the two main ones that are available right now. So for paramedics, conveyance is always that kind of sunny pathway, taking someone to the emergency department. There's social workers at the emergency department, so there's likely access there. There's referral resources. There's a link to ongoing support potentially, and it moves that ball to somebody that might be the expert. Whereas non-conveyance, that patient's probably lost to follow-up. If they don't do a self-referral, as right now paramedics aren't engaged with this referral process, they could be gone altogether. They could be at risk of repeated violence. And it's a very different intersection if we switch this from that paramedic perspective to the survivor's perspective. Because sometimes what we've been seeing through different things is non-conveyance might be that preferable option for survivors of violence, whereas conveyance might be a little more challenging. And what that can look like is survivors get to stay at home if they're not conveyed, which is preferable to sitting in an emergency department. We've all done that for a long time, I'm sure. They get to stay with their children. That's a huge part of these situations. They can avoid the stigma and embarrassment of accessing healthcare and going through all those different pieces, and the situation will just kind of go away. Versus the judgment you might get at the hospital, the long wait, the negative experience, and it doesn't help anyway. And neither of those opinions are right or wrong. They're just based on the experiences of those people. So just kind of keep that in the back of your mind as we move forward the rest of things today. So continuing the background, there's a really big opportunity for paramedics here being in that unique position. Paramedics could be an expert resource for survivors using those skills that we already have to position people to access healthcare in whatever way is most appropriate for them, for these unique situations involving violence. And there are multiple pathways that could be included here as well. It doesn't just have to be conveyance or non-conveyance. There's the opportunity as paramedicine continues to grow and we're becoming less of these crudely put, like you call, we haul services, and more of these interdisciplinary healthcare professional services. So there's a ton of opportunity there. And one big piece, and I'll touch on it now and then we'll come back to it later, is the opportunity to recognize, respond, refer, and record situations of intimate partner violence. So these are some of our kind of guiding principles that are emerging right now. But there's this huge opportunity for paramedics to be that kind of vital link. And so to make this super clear and just to give you a good visual representation, because I know death by PowerPoint's not fun, so I appreciate you all in advance hanging with me today. I'll try and keep it as interesting as possible. But if we have survivors of intimate partner violence on one side of this gap, and then interventions to support survivors, and in this specific setting through paramedics, right now, we need the knowledge to inform these interventions and to figure out what's going to work, what can help us best support survivors and the agencies that support survivors. And that's what we're missing, because once we've got that, we can move our interventions and hopefully bridge this piece and fill in that missing gap. So that brings us to the research objectives. And this is a line of ongoing work. We're super excited about it. There's a ton of work happening, and this is 3 main projects that are happening right now, specifically related to paramedics. So first, we wanted to describe the current state of paramedicine and understand what that's like from the paramedic kind of position and how ready they are to encounter violence. The second one is the patient perspective, and we miss this all the time in healthcare. We ask doctors and we ask nurses and we ask experts in the field who think what we think should be done, but we rarely ask the patients. And so that's something, and using the term patient here and that healthcare context is something we really wanted to gather moving into this work. And then also encompassing that really important paramedic perspective and trying to put all this together. And the goal of all these research objectives and the goal of everything we do in BOLD is to improve care for survivors. And that's a really broad statement, but this underlines every single thing we do. So if we take those 3 research objectives, these are the different projects that we're using to approach those. Our first one is a survey study of paramedics. Our second one is our patient study, so doing some interviews with survivors who have been attended to by paramedics. And our third one is the study of paramedics themselves. So let's move right into the survey study. This is currently under review, so this will be published shortly and then be readily available. But that objective, again, is to characterize the current state of paramedicine in relation to intimate partner violence. So to do that, we did an anonymous online survey of paramedics in Alberta, BC, and Saskatchewan. So Western Canada just has a very similar paramedic education and similar geographical constraints and scopes for paramedics in that region. So we're isolating kind of the West at the moment. And then we're looking at readiness. So this is how ready you are to encounter a patient experiencing intimate partner violence. And you can think of that like how ready you are to get dressed and go to work in this morning. Like that typically resonates with people, I find, where it's how do you feel about that? Are you terrified to go in and you're not sure what you're doing, or are you very comfortable going in and doing your role? So that's what we mean by readiness when we're saying this there. The next piece, and this was really important to us in pushing this motion forward, is there a desire for additional education and training among paramedics? And then a piece that we talk about and is becoming of growing interest and consideration in paramedicine is this IPVBI. And so you'll see that term periodically. That's referring to intimate partner violence caused brain injury. So brain injury is acquired through experiencing violence. We're seeing a lot of this emerging lately. And then that adding challenges in how people access healthcare, how people recover from violence. If we contrast that to sports concussions, for example, where a player may sustain a concussion, be removed from play, have expert care, expert rest, expert treatment, all these things, whereas a survivor of violence may experience violence and have a concussion or a traumatic brain injury, and then still have to get up in the morning and parent and go to work and potentially be exposed to violence that next day. So it's just a really big piece of the picture. And moving forward, we want to make sure this is included in all the violence related work we do. And that also extending to non-fatal strangulation as a mechanism of acquired brain injury. So the survey respondents, so who responded to our survey, we had almost 700 paramedics respond, which was a really great turnout, especially in the post-COVID era or the post-pandemic era, let's say. There's more survey research going on than ever before. So to get this many paramedics was a really huge feat, and we were really thrilled with that. We had 48% of women in our group, 41% men, just under 1% non-binary, and then about 8% didn't respond to our gender question. And about a quarter of these folks had previous experience with IPV. And I just want to highlight that that's not necessarily having experienced intimate partner violence themselves, but more so just additional familiarity. So that could have been experiencing violence themselves, or supporting a family member or friend through it, or working at a shelter, or taking additional courses in higher education, or anything like that. Just awareness above and beyond what might be typical. So we had that piece. So if we just jump right into the results, this was a big study, but I've tried to make it as clear and condensed as possible here. So this is our total outcomes here. All the little dots you can see on the screen there indicate individual responses, with the boxes behind them being kind of the bulk of those responses. And then I'll highlight the averages as well. So total readiness, bringing your attention to that top yellow box there. And in this scale, 1 along the bottom would be the lowest possible score, the worst score, whereas 7 would be the most ready or the best possible score. So you can see relatively, paramedics, that's the middle there, we're sitting at about a 5.4 for total readiness on a scale of 1 to 7. That's not too bad. And it was better than where we thought it would be. So the next piece is self-efficacy, emotional readiness, and motivational readiness, and IPV knowledge all go in to make total readiness. So those next 4 combine for total readiness. So we've got some really interesting findings here. So self-efficacy, so that belief that paramedics can do something in these situations, was one of our lowest scores at 4.8. So quite a substantial difference there. And just showing that is lacking. That belief that paramedics can perform in this role was lacking among our respondents. The other one, right comparable there at 4.9, is emotional readiness. And so that's as implicit as it sounds. The emotional readiness of how emotionally prepared paramedics were to encounter violence, also on the lower side of these numbers. Whereas motivational readiness and IPV knowledge, so this is just knowledge of IPV in general, were quite high. So paramedics have this desire to help in motivational readiness and this want to help, but just looking like they're not emotionally ready and don't believe they have this aspect. And then again, like IPV knowledge was relatively quite good, 6.0 there. So on the higher end of the spectrum, which is really interesting to think about because chronically people point to increased education and training. And I mean, our knowledge was good, so maybe our education could be added to, but maybe isn't as important as approaching some of those self-efficacy and emotional readiness pieces in this. And then the final one, I'll bring you down to that blue box at the bottom with IPVBI, so that brain injury knowledge. So this is a form or a tool we've made for the project specifically and isn't a part of total readiness. And this was our lowest score. So this just highlights that intimate partner violence caused brain injury knowledge isn't being built into the current understanding of intimate partner violence, even when we've got this set of paramedics that's actually not too bad at it. So that piece is missing. But another huge finding from this study is that 96% of paramedics desired that additional education and training. And that's huge. That want and that desire to do better in this area showcases just the opportunity for growth in this area. Really, really pleased with that outcome and that the profession is looking to do more and expand more into this field. So to highlight some of those points, I have been known to talk too fast and too quickly. So at the risk of repeating myself, just try and make this very clear. Readiness was all right. It was better than we thought it was going to be as the research team. That total readiness score was relatively good considering that we're not educating, training, or equipping paramedics to be ready. They were still fairly ready. So that was good. Knowledge and motivation were high. Paramedics are knowledgeable, functionally knowledgeable, according to this tool, with intimate partner violence and motivated to support survivors of violence. And that's huge. Like having a group of people motivated to help a group of people is challenging. So that was super high. The downside of this is self-efficacy, so that belief that paramedics can do this, and emotional readiness, just how full is your emotional cup to go and support people today was low. And that's challenging. But I think those aren't insurmountable challenges, and those are things we can broker as long as we are aware they exist, and that's part of what we have to be targeting moving forward. And the next piece of this, we had some factors play into those answers. So gender and IPV experience, and I'll talk about each of those separately for a moment. So gender, we had an overrepresentation of women in our survey respondents compared to the paramedic workforce. Seeing about 30% women in paramedics in Western Canada, and we had about 50% of our survey respondents. And considering gender had an effect, we might be seeing a higher level of readiness in our survey respondents than is representative of the greater paramedic workforce. And then similar with IPV experience, we're seeing 1 in 4 of our survey respondents, or that 25%, has some previous experience, and that might not also be representative of the general population. Just 2 factors to consider, that although we saw this in our group of respondents with those highs and lows, it might be slightly shifted and probably would be for the greater paramedic workforce. But that desire for change is still huge, and we're really excited by those results. They're really, really promising. That paramedics themselves are eager to advance in this area. So that's our first glance at paramedics. Let's shift gears and look at the survivor or the patient study that we're doing at the moment. So the objective of this study is to learn from that patient perspective. And this is so valuable in those experiences, this information, we just can't get it any other way. This has to come from people with that experience in these situations and being treated with paramedics when you're in this high acuity crisis situation. If you think about being a paramedic for a moment, you're attending the worst days of people's lives frequently, and you're coming in as this person that's there to help, and that's kind of the mindset paramedics have. But the other side of this is the person that you're going to. This could be the worst day of their life, and so it's very important to get that perspective as we move forward with it. So to do this, we're doing interviews with survivors of IPV. These are one-on-one interviews. They're conducted by my wonderful colleague, Nicole, who's a paramedic, a nurse, and a researcher, and does a phenomenal job interacting and engaging in these interviews. And I can't say enough good things about her. Just a real privilege to work with her. So she's been doing these interviews with women who were seen by paramedics or attended to by paramedics. And these are ongoing projects right now, so we've done some preliminary analysis, but I expect this data will change and grow as we continue to work through it here. Yeah, so we're doing these interviews across Western Canada with different survivors and just really looking to gain that patient perspective. So the anticipated results, and again, this is anticipated because it's ongoing, but these are some themes we've seen so far. So inappropriate approaches is a common thread, and what that's looking like that stems from is how paramedics are approaching calls, what injuries and injury patterns paramedics are thinking of, what treatment destinations people are going to, things like if a patient's, let's say, reporting a loss of consciousness, typically that goes to a hospital, if not a major hospital, versus patients reporting that with consistent injury patterns and then being taken to an urgent care or left at home. Like these kind of not medically sound approaches that I think if you take the violence piece out of it, paramedics wouldn't make those same decisions, but because there's this violence piece and potentially the overlap with different factors, addictions, mental health, all these other pieces that closely overlaps or can closely overlap, that there's just, it clouds that practice. And so we're seeing these inappropriate approaches and patients having kind of different experiences based on that. The next one is police involvement. The police attend far more violence-related incidents than paramedics do, just in the nature of how those calls come through 911 dispatch. And we're hearing some really varied approaches and pieces on that. Some had great experiences with different officers and detectives and victim services and things like that, whereas some did not. And this wasn't a central piece of what we were looking at, but a huge factor that just keeps coming up over and over again. And so we'd be amiss not to mention it there. Another challenging one is paramedic disbelief. And again, these are from those patient perspectives where they felt like the paramedics didn't believe what they were being told and maybe not believing the extent of the violence. And I think that that's a tough one to swallow, because we'd like to think that our healthcare providers in these settings are working with our patients to get their best available care, and hopefully that's something we can work towards moving around in the future. And then the final one that we've teased out at the moment is just the repeated intimate partner violence and the repeated attendances by paramedics. So we're getting a lot of contact points with survivors. It very rarely, at least in our interviewed sample or interviewee sample, is there one paramedic attendance and that's it. It's typically multiple attendances over multiple time periods, sometimes for the aggressor, sometimes for the survivor. And so we're getting a lot of contacts, and those repeat contacts are really important if we think about recognition and steps to recognize. So if it's not the same paramedic crew going every time, are they going to have that higher index of suspicion and things work in that way? So there's that piece of it. And that's what's emerging so far from this survivor or that patient study perspective. Now, the next piece is the paramedic study. This is still in its very early phases, but is ongoing as well. So this is just to capture that paramedic perspective, to complement the patient perspective and look at barriers and facilitators and experiences in that same kind of manner. And this is interviews and focus groups with paramedics, again, across BC, Alberta, and Saskatchewan. So the preliminary results on this side, and again, this is anticipated and preliminary. Paramedics are frustrated with the lack of options for survivors of violence. In a lot of spaces, your treatment pathways are to the emergency department or no treatment whatsoever, no referral, nothing. And that's super challenging because we're seeing that paramedics are recognizing the transport to the emergency department isn't the best fit for everybody. But at the same time, when there's no other options, then that's a big barrier right there, a real rub point. Another piece that's coming up is complacency. This, let's say, misinformed attitude that and misconception and frustration of paramedics being like, why won't the survivor just leave that relationship and that situation, and just being very complacent to those repeat attendances. And I would speculate that that comes from a place of lack of understanding and lack of awareness in the complexities and the lethality risk in those places. But the complacency piece is really starting to emerge, and I think that's something that's approachable as well. The very positive one, but with the spin on it, is paramedics are, and echoing what we saw in our survey, that desire to help, and they want to help survivors, but with those lack of options and them becoming complacent because there's a lack of options and not seeing a path forward, paramedics can be really unsure how. They show up and they're just not sure what to say. Do they ask about violence? Do they not ask about violence? Where does that all play together, and how does that all come? And then role discrepancy. And this I hear from paramedics kind of through informal conversations, but also through kind of preliminary pieces of this study all the time, as like, well, what can I do? What can I do in that 20 minutes to the hospital, or that 30 minutes at the house and the 20 minutes to the hospital? Like, I can't fix the problem there. And my kind of counter to that is, well, you can't do an angio and go and break up a clot in the heart in that time either, but you can set them up so that when they get to the healthcare system, that they can get the care they need. And that's kind of coming around as well. But just this discrepancy of what can the paramedics actually do? And I think with that desire to help being there, if we can clarify that up, provide some more options, and get away from that complacency, that we could have a really successful piece here. So just to summarize all those kind of thoughts together, paramedics are knowledgeable and want to help, but are lacking that self-efficacy and that situating and that infrastructure to help that move forward. Survivors have reported mixed experiences dealing with EMS. We have some phenomenal practitioners that do a great job for our survivors and just patients in general in a system that doesn't accommodate it. But more commonly, survivors have reported to us negative experiences, and that's something we obviously want to change and work against. And then paramedics are reporting systemic and professional barriers. But again, that desire to help is there, but it's going to require infrastructure. And just to highlight again, those are preliminary results, but that's ongoing and likely to emerge in similar themes. So I know I've been kind of discussing and reporting the results there, but a little bit more discussion here. And just that paramedics do have this really, really unique role. And we know that survivors are seeing paramedics and paramedics are seeing survivors. And we're so far behind in paramedicine, but specifically paramedicine in Canada, this isn't an established fact. We don't have that landmark paper or published evidence or pieces to point to for this. And so that's how far back we are at the inception of this work, and that's something that we're working for at the moment. But paramedics want to help, and I think that would be a common thread no matter what the title is across the board. Paramedics, you don't go into a career like paramedicine without a desire to help people. It's just, it's in the nature of it. And if you want to work in healthcare, there are roles that make more money with better working conditions and more stable environments. But paramedicine is this unique piece that's kind of this magical gray area wasteland where there's so much opportunity for the role to expand and people that do a phenomenal job in it. And the people that go into that role in this complex, ever-changing environment have this desire to help as a common theme. And whether it's help their community or help the population at large, everything, it's just this desire to help is kind of this overwhelming wave that comes with paramedics. But we have to acknowledge as well that changes are needed to achieve these things. And so we're going to shift gears a little bit here and move towards kind of some pathways to care things that if I had my kind of pie in the sky, cloud nine of what we could do and how we could move this all forward, this would be my starting point from the paramedic aspect. And then with that piece, then we'll get into some more actionable items for paramedics and then just people in healthcare in general here. And this is a super this is a really exciting piece for me because I think we're getting really close to where we need to be with this to make some big changes. So the first big one, and I'm using this green rectangle as the backdrop for this, is education, training, and infrastructure. And it's kind of a chicken or an egg, which one's first? It kind of has to be all at once because if we put the infrastructure in and there's no education and training, people don't know how to use it, it will go by the wayside and become useless. If we educate and train people and then there's no infrastructure, that also goes by the wayside and then it's useless. It has to be this synonymous, synchronous push to go, okay, educate, train, and support, situate at multiple levels across organizations to make this all come together. So now with that as our back burner, we'll walk through kind of an acute pathway of intimate partner violence in this ideal world. So, well, ideally there would be no violence, but in a situation where there is violence, what happens next is the ideal circumstance from where we are right now and kind of our current understanding. So in an IPV incident where then there's 911 access, first, we would have that location data, and this is a feedback system, whether it's address flagging or call flagging, repeat address or call number things, where there's just that extra added level of infrastructure for recognizing violence. So if there's been 3 violence-related calls at this address previously, there's that kind of awareness going in. And there's this IPVIQ, which I just use kind of throughout this slide as like that knowledge, awareness, understanding, and kind of radar for it. So when people are calling 911, let's use the tools we do have, which is their addresses and interagency data, so police, fire, home care, all these different things to help raise that index of suspicion and work towards recognizing this here. And then just have that awareness cycle through this as well. What's being said on the phone? Who's calling? Where are they calling from? Is the call cut short? Is it a text to call? What's happening with all those pieces? Then have this appropriate dispatch. And there's a few different components to this. A huge one is safety. And this is both patient safety, caller safety, bystander safety, whoever's in that house, but also paramedic safety. And I mean, that's the first step in any first aid book or anything is make sure that scene is safe and we can go in that way. And whether that's through police involvement or paramedics are able to navigate that independently is going to be dispatch specific, but it's just got to be that appropriate dispatch, prioritizing safety, and then that dispatch also having that IPVIQ to move forward. Then we'll do this again with the on-scene response. So when paramedics are getting to the scene, safety and IPVIQ is huge. And this on-scene piece, we could dive in for a very long time too, about all the different components that would make it really, really functional, and all the different tactics. Like just a few examples. Often if the aggressor is there, or suspected aggressor is there, paramedics can kind of divide and conquer. It's really nice if the joke of like paramedics, pair two. And so you get somebody like, oh, hey, can you help me find a sweater or something that's blatantly not in the room, like a jacket or a pair of shoes for your partner. And so one paramedic takes the other person away and then creates that space for the other paramedic to have those discussions, or at least to kind of gauge those things. It was really functional during COVID. We could move one person to the back of the ambulance, be like, oh, COVID restrictions, sorry, like we can't have you back there, and then have that private space to have that interaction. So just all those little things, and integrating some of the approaches, the recognition, response, referral, and recording that we're going to talk about in a little bit as well in that on-scene piece. But just having paramedics bolstered and situated to be these professionals that when they're there and these situations emerge, that we can recognize it and move forward. And then there's these pathways. And so this is the current pathway, which would be emergency department transport, and then this link to, and that's a very small portion of this table because this is really focusing on that paramedicine piece, but it's the biggest portion of this whole piece is that ongoing, like and don't try and read the slide, it's intentionally small, but all the education, vocational services, government services, all these different pieces that can be set up as resources for support survivors of intimate partner violence that can be accessed through the emergency department. And this is also with the consideration too that in settings of acute injuries, that people do need emergency care. There are all those other kind of psychosocial, socioeconomic pieces of these puzzles, but built into all these pathways is like, though that emergency care is priority number one. But then pathways, as you'll see, I've suddenly bolded and underlined in the title of this slide, refers to more than one pathway. And so these are just a few examples. I just built 3 into this, but IPV specific resource transport, whether this is to a victim services center or a women's shelter or specific areas of the hospital, specific clinics, things like that, where they're specifically set up to deal with violence, and then loop people in to that bigger network of resources as well. And this one's really important and is kind of my like, hey, like we need to do this for sure 100% every single time as we move forward in this, is that non-transport referral. So in situations where people can still be safe at home and there are danger assessments and things for that, or people don't want to go, and that's a misconception about paramedics. We don't take anyone that doesn't want to go. We can't kidnap people. We can just provide them with information and let them make informed decisions. So there needs to be these pathways for non-transport referrals. So people are still linked to the network and receive that care, even if they don't want to be transported to go into the hospital. Leaving your home to go and sit in the emergency department when you've just gone through something extremely traumatic should not be a barrier to receiving care, support, resources, referrals for that. And now thinking about this piece, there's a ton of different minor semantics that play into this and how you could do this from a back-end standpoint that I'm happy to discuss at a later date with anyone that's interested, or in the Q&A. But this is just a very kind of big picture, big concept for how we'd like this to go. And the other thing is just playing this ongoing role of looping through and making sure that all these resources and this link and that network is accessed and there's follow-up. And so we're supporting survivors through that journey as well. And that might not be something that falls on the pre-hospital paramedics, but just something that we need to build into this pathway. Because again, although it's the middle 2/3 of the screen, the paramedic portion of this pathway is really the entry portion in this framework. But if we think about that portion right there, if we don't do this, then none of this happens. And if we miss at any step of the way, then we've missed. And now that person's at risk of repeat violence and all these things. And they may access resources, they may not, they may want conveyance, they may not. It's someone else's life, right? It's going to be their choice and their situation. But 10 times from now, 10 incidents from now, they might go, you know what? I actually now I'm set up and equipped and ready to go and move forward and look for a way to get out of this situation in a safe and supportive manner. And that's really what we've got to look at moving forward here. So keeping on that theme of moving things forward, some actionable items. I'm just going to dart into a few of these really quickly. We are nearing the end, and I really appreciate you staying with me for this portion. I know my voice isn't as soothing as Morgan Freeman or anyone like that. So hang on for a few more slides here, and we'll get some really meat and potatoes stuff. But just the lives approach, 4Rs, the brain injury component, non-fatal strangulation, and advocacy. And so I'll just touch on these each quickly here with some visuals. So lives, this is from the World Health Organization, is just a very simple, moldable framework to apply to working with survivors of violence, and just listen, inquire, validate, enhance safety and support. So listen without judging, inquire, figure out what people are needing, what they want, validate that experience. There's so much emotional kind of gaslighting and manipulation in these settings, and people just adapt to cope with the new normal. So that validation piece is huge here and just really important. And World Health's done a great job of putting this together. And then enhanced safety, like anyone that works in the space understands that the lethality risk, especially when leaving situations of violence or as violence is escalating, is really high. So the last thing anybody wants is a violence related homicide, and just doing what we can to help position people so that doesn't happen. And then support, connecting those referrals. You're going to see a lot of overlap in these actionable things because they hit a lot of the same big themes. So that's the lives approach. If you Google World Health Organization, lives, anything like that, it should come up. And then this is the 4Rs approach. Don't try and read this slide. I'm going to put some bullet points up on the side that make it easier. But this was developed by Simon Sawyer and colleagues, and is that recognize, respond, refer, and record. So this is specifically developed for paramedicine at the moment. So recognizing violence, recognizing signs and symptoms and behaviors, and controlling people and trauma. And then if you're suspecting intimate partner violence, asking about it, seeing what that's like, and knowing what to say in that response, and putting some tools together there. And then referral. We're not expecting paramedics to be expert social workers or crisis workers in these specific ways, but we can expect paramedics to link people that are experts through. And that's a really big piece. And then record. And this seems so fundamental, but it's currently missing in a lot of frameworks. Is we have to document the things we've seen objectively, those conversations, so that it can be advanced to the next person in that healthcare pathway, because healthcare in general is a team game, and we need to just move forward with that. So again, this is what I've termed the 4Rs, but this is the current paramedic guideline. It's preliminary. This was developed in Australia, and we're looking at continuously implementing this and improving it. And you can see it's got the lives approach across the bottom there as well. So those are just two very simple things that can be applied to anything really working with survivors, but specifically healthcare, and even more specifically here in paramedicine. And then again, moving to that brain injury piece, intimate partner violence caused brain injury, IPVBI. Don't read this middle slide. This is just so you didn't have to look at nothing while I talk about it. But this was developed by Mike Ellis and colleagues, and it's just a flow chart for medical practitioners on how to incorporate that brain injury piece into assessing people that have experienced intimate partner violence, and then referrals and treatments and things like that. A really great tool, and definitely a great resource there. Mike Ellis is a great doctor in Manitoba that's forwarding this work, and is one of the leading voices in it. And then staying on that kind of brain injury theme, unfortunately, is this non-fatal strangulation piece. And this is graphics from the Strangulation Institute, or the Training Institute on Strangulation Prevention. They've got a wealth of resources up there as well, just things to look for. Gold care standards. The standard currently is we want a vascular CT for that neck vasculature when people are attending the hospital that have been strangled, just because if there's damage there and then 2 weeks later they have a stroke, that may never come back to violence, whereas we want those things documented early and often and then be treatable from there, ideally. So just all these things to play into, and there's a ton of resources to help action these components, but it is a lot, and definitely lots of great tools. And the kind of final piece that I want to mention is I see the violence sector probably moving towards this joint violence and exploitation Venn diagram of overlap, because there's so much overlap. We see a lot of human trafficking and slavery situations, and not in the human trafficking, you see so much in kind of the buying and selling of people, but more in exploiting someone for basically service to you through controlling their phone, controlling their finances, all these different things as portions of human trafficking. And so this idea behind violence and exploitation, and just building those components into your practice is really important. But the big piece, and outside of tools, outside of everything else, there's one thing that people that want to help can always do, and that is just advocacy, advocacy, advocacy. This is going to be huge. Advocate for your patients, advocate for your friends, advocate for your family members. There are things going on. Violence is challenging, to say the least. So advocate, advocate, advocate is the biggest thing. And it'll just should help move it to the next step. You don't have to remember 4 R's or different acronyms. If you just advocate for people, that is a huge, huge support. So looping back here, hopefully through my ramblings, we've got a good understanding of the current state of paramedicine and intimate partner violence in Canada, and that there's this opportunity to activate paramedics as this resource and support survivors. Hopefully we're able to get to both those things today. And just some key points here to take home. So IPV is a common criminal, social, and health issue. Paramedics could be an export resource for survivors. Currently, paramedics require improved education, training, and infrastructure, and future paramedics have the opportunity to be essential healthcare advocates for survivors of IPV. And when in doubt, just advocate, advocate, advocate. So next time, my hope is that in the future, when paramedics are in a situation like this, and they walk in to somebody like this, they won't have to ask what to do or wonder what to do, that they'll know exactly what to do. And thank you so much for your attention. And I really appreciate you taking time out of your day to listen to me share some of my team and I's work. So thank you so much. And thank you, AVA and FREDA, for the opportunity.
Thank you so, so much, Rory. It was an excellent talk and I learned so much. I really appreciate it. And I feel like a lot of people share my sentiment. Would you like me to read the questions, or do you want to pick some from the chat on your own?
If you would like to read them, that'd be fantastic. Thank you.
Sure, absolutely. And if anyone has any questions, you can either put your hand up or put them in the chat for us as well. So Faith asks, how do paramedics help someone experiencing IPV at street level?
Yeah, that's a great question, Faith. Thank you for that. There's a lot of different ways we can do that. I would say in the current state, just understanding how it works with violence, recognizing that violence might be a part of what's happened today. There's a real range of things that can happen in ambulance calls relating to violence. So, for example, a call could come in for a fall, and you get there, and the mechanism of the fall and the history of the fall doesn't quite align with what you're seeing, and kind of maybe patterns of disarray in the house or things like that. And so how paramedics could help on street level there it's going, okay, well, we're always talking about this kind of spidey sense. And it's like, okay, well, if you have those suspicions, um, getting to a facilitating environment where you can ask about, is violence a factor, or universal education, and then always doing this in a safe way. If there's somebody that's potentially an aggressor right there, you're not going to say, oh, and people often experience violence. Here are some resources that you could share with friends or family that might, like, situationally you want to be, coy is not the right word, tactful in moving that around. Whereas a situation where someone's called for a violence related reason, the police have called us because they've recognized injury and need for us. The violence is aware. It's still good to ask about it and initiate those conversations. And we find the research shows, not necessarily in the pre-hospital setting, but in healthcare, people in general are open to being asked about violence. And there's no harm in doing that generally. So that's a big concern often in healthcare providers. But at the street level, just opening those discussions, recognizing violence, and then kind of advocating and moving the ball forward. And at the moment in a situation where it's not super set up for paramedics to do that, just kind of being as adaptable as you can, as paramedics often are, and making situations work. Hopefully that captured the nature of your question there. If there's any specifics, feel free to put them in the chat, or I'm always happy to share thoughts later. My email's on the screen there too. So
That's great. Thank you. And there's a lot of thank yous and voices of gratitude in the chat. So I hope you do check it at some point. Carrie says, really great presentation and congrats on the great research. What are the plans, if any, to implement the recommendations, and who will be responsible for the action items?
excellent. Thank you. That's a really great question, and something that we really like to drive home as well is that with this research, we don't want this to be a survey that's studied and a population of survivors that are studied and paramedics that are studied, and then that get published and I pat myself on the back and then that goes to live on a shelf and never be seen again. We really want to move it to actionable items. And so over the next phase of this is moving it into action. There's some really great work going on right now that we're supporting with the ambulance service in York, and they're looking at what they're going to put in to support survivors better in that area, and just some really functional things. There was a report that I wrote for the coroner's or the Ontario Coroner's Office after a violence-related homicide that has a lot of actionable items in there. And so we're kind of using that as a bit of a framework. So who's responsible for it? Broadly, paramedicine in general, echoed by some loud voices, me being one of those loud voices. And we've made a really big push with the Paramedics Association of Canada to get intimate partner violence and extending to brain injury and non-fatal strangulation into the education and the training, and the guidelines. And then once it's in there, everybody that complies, so the provincial regulators, and then that filtering down to the paramedic organizations and paramedics, will have to comply to be Paramedic Association of Canada compliant. So that was a huge piece, is getting in with the pack and making that a competency and a component, at the same time as our group is working with different organizations, supporting York to put some implementations in, developing tools so that when somebody goes, hey, what can we do? We have a list of things that we can do. And, these are quick and free. These are more expensive, but really impactful. These are very expensive, but very impactful, kind of those things. And using some implementation or knowledge translation frameworks to do that. The knowledge to action cycle is a very user-friendly one, developed in Canada with a ton of resources to help do it. And yeah, so who's responsible for it? We all are. And it just is keep, like, being that squeaky wheel is something I try and do And I'd like to move this forward. I don't want this to die on my bookshelf. I want this to move forward so that we can be these expert leaders and resources that can actually support and benefit survivors.
That's great. Thank you. There are a lot of questions rolling in, so I'll just keep bringing them forward. Kimberly Drake says, this is excellent. Thank you. Do you find there is a difference in response to rural versus urban locations?
Thank you, Kimberly. That's a great question. Short answer, yes. There are a lot of different resources. Typically, I'm just outside of Calgary, Alberta currently, and we have several major shelters. We have different victim services. We have different clinics at hospitals. We have women's health centers. Everything is here. And if you're inside Stony Trail, it's within a 20-minute drive to any of those things. Whereas I spend a lot of time in northern Alberta and parts of rural BC, and there may be a small shelter in a small town 2 hours away, and that would be your closest specific resource. So then if we extend that to the paramedic approach, it can be more complicated to align people with resources when they're further away. We're making some really good advancements in telehealth and virtual health that is helping knock down some of those barriers. And then people even going to a hospital to use a laptop to access a telehealth appointment somewhere else. Like we're working with the technology that's available, but there are definitely barriers in underserviced areas, and it is just a component we have to build in. But there are differences. The principles remain the same, but there are definitely differences, and we hope to kind of work towards getting some health equity in built into this process as well.
Thank you, Rory. Although these ones aren't really questions, more so statements. If you people are wondering around what the research might look like in the future with respect to men who are victims of intimate partner violence and those who are part of the LGBTQ2S plus communities, is there a way to speculate a little bit around that?
Absolutely. I actually remembered I normally make a point about that in one of my introductory slides and just missed it today. And then when I remembered, I was halfway through something else. So sorry about that. Yes, absolutely. I'm not discrediting violence against any specific group. The groups we work with primarily are women. Our team, we have Tori Stranges is in our group at UBC, and she's doing some amazing work in the 2S LGBTQ plus community, specifically around violence and in sexual and gender minority folks, and just keeping that area and highlighting it as well for an area that needs investigation and intervention. We do see that rates of violence are higher proportionally in that population as well. So we definitely want to make violence support inclusive to everybody. And right now we're targeting areas that are affected the most of the time in the most severe ways. But there are going to be, let's say, specific contextual differences in maybe how things are applied or norms within different communities, and how people access healthcare, like violence against men, as well as a piece of this. Often it's documented as being less severe, and so there's that component as well, just trying to do the most amount of good with the resources available, but definitely acknowledging that violence affects everybody and keeping those pieces going as well. And then especially when you integrate factors that relate to experiencing violence in childhood and youth, and then how that translates into adults and relationships and things like that. There's a lot of variables, and so there's some great work happening in a lot of different areas, but our group is investigating that as well, and we're just trying to figure out where our resources can align. But I think the principles would be the same. Like if you use those 4 R's principles, we could apply that to any group. If we use the lives principles, we can apply that to any group. And those base pieces will be the same, and it'll just be those amazing frontline experts that we have that are able to adapt those tools to their settings. And hopefully paramedics should be that for not just women, but everybody that's affected by violence and exploitation.
Such a thoughtful answer. Thank you. So far, there's one more question in the chat. I say that to continue to open up the floor if people have additional questions. But the last question we have so far is from Madison, who asks, curious how this approach may influence the criminal justice process. For example, if you're supporting a victim and they are open to you, but provide conflicting or minimal information to the police, could paramedics be subpoenaed to court?
Yeah, that's a great question, Madison. You can always be subpoenaed to court, which is a component of this, and why I always make a big push to any of the students we have in, or just paramedics in general, like make sure your documentation is good, make sure that it's accurate and objective where it needs to be, and then noticeably subjective where it may be. There are different situations, like one that comes to mind, we have quite frequently in discussion with new paramedics moving through the training programs. They'll say like, oh, well, what if the patient told me they were drinking, but they don't want me to tell the police? And then the police ask me, and regionally dependent on your policies and protocols and legislature. But typically, my advice is to say that the patient tells you things, you document in your report. You can write patient stated this, and then if the police are looking to subpoena something, that, or the prosecution, I guess, not so much the police, that's always at their disposal. So it's a tricky line, and that's one of those gray area pieces that facilitates really good discussion. At the end of the day, you wouldn't want to break trust with somebody that's confiding in you, unless it's a direct threat to their safety or the safety of a child or somebody else, like those specific circumstances where it's those mandatory reporting pieces. But and I mean, honestly, it's very challenging to get convictions without a lot of very specific things being in place. So if somebody's not willing to, or isn't situated, or whatever that may be, and that's so complex, if all those things aren't in place, it's unlikely that that's going to be able to move forward from a criminal perspective anyway. So I think prioritizing the patient safety and health and well-being and access to ongoing resources has got to be the priority. And although those kind of legal considerations are important, they're secondary. Our group put out a paper looking at the ethical legal considerations around documenting and acknowledging intimate partner violence caused brain injury, and the potential for, and this seems like it should be illegal, but probably isn't, but for a lawyer to use the brain injury that let's say a male perpetrator gave his female partner, as like weaponizing that to then win a custody dispute because of the brain injury. Now she's not a fit parent, even though he gave her the brain injury which caused that piece. And so it is very complex. It is very challenging. And as to my knowledge, that defense and that argument has not been used to date, but I'm not a lawyer, and I don't keep up with that as much as I could. Is it likely to happen? It's very possible. And so hopefully there will be some legislation and some policy and some support around that to help shape these situations, because yeah, again, with paramedics, we want to help, and we want to make sure that what we're doing is going, or is situating people in the best possible space to help. So yeah, the documentation and disclosures and that piece is always very woven. And from the paramedic context, and this is just something I always like to kind of bring it back to, because paramedicine for a long time is built on physiological emergencies. So which is basically, is the number too high or too low? Is the heart rate too high? Okay, let's bring it down. Is it too low? Okay, let's get it up. Same thing with blood pressure. And to a degree, that's really easy. Numbers are really easy. Looking at socioeconomics and living status and finances and social stigmas and all these different pieces are very complicated. And it's this overlap between those two things that we can see in physical violence, where there's physiological issues, but also psychosocial issues. And the Venn diagram is tight. And yeah, it is just very, very complicated. And we sometimes go down kind of the what if rabbit hole in classes with new students coming through. And there's so many situations. And at the end of the day, if your frame of mind and space is just, I'll do my best for this patient in this situation, in this context right now. And that's all we can really do. Or that should be the base principle of all that we do. And yeah, just do your best, especially right now where the infrastructure isn't there to support it. And there's not as much guidance on this, because it is a bit of a can of worms when we start getting into these things on as paramedics, but at the same time, it's a very relevant and crucial and huge portion of our patient population can of worms. And can of worms probably isn't the best term, but we need to be functional for that portion of our patients as well. Not just patients that are in cardiac arrest and having strokes. Not that those aren't important, but these patients aren't any less important.
That's great. Thank you. We've had another question added, which is from Tiffany. Do you have any information on how current interactions with paramedics during IPV situations affect victims' likelihood to call for help in subsequent IPV situations?
That's a really good question. I have a very small amount of evidence on that, but I can speculate probably fairly accurately. If someone accesses EMS for a violence caused situation and has a negative experience, they're probably not as likely to call again. Whereas if they call and have a positive experience, even if it is a similar situation and so on and so forth, they're probably more likely to call. And that would be my general kind of statement or speculative statement on that. It is tricky. Like we say this all the time, all the paramedics are very tongue in cheek, but I was like, we all look the same, we're all wearing the same shirt. And so we see it with patients in different settings, and I've seen it anecdotally with patients in different settings. If I show up and the last time the patient was seen by paramedics, they're like, oh, you don't need us, it's a waste of our time, you blah blah blah, yeah. Do you think that person wants to see me next time they need help? No, it's the same brush. And paramedics can do ourselves a disservice when we have those negative interactions for the next person around. In the same way that we can also do ourselves a positive service, that we can set the next person up for success if we have a really good experience the time before. And so, yeah, I think if we were consistently, more often than not, doing a great job or a really good job, or the patients were happy with how the outcome was, then we would probably be more likely to see people asking for help when they need it. Whereas if we don't do a good job, or heaven forbid we make it worse, then we're probably not going to get that opportunity to intervene again, and that's a real miss on our end and in our area. And again, like, we have great paramedics that do a great job, but sometimes we do miss, and it's very, very unfortunate.
Absolutely. Thank you. So I don't see any more questions. If anyone has a quick question, we have a little bit more time. If you want to raise your hands, I'll give anyone a minute. All right, I think that wraps up the questions and wraps up such a wonderful session. Thank you, Rory, so much for your fantastic presentation, such great information, and also so eloquently fielding really important and nuanced questions. So thank you so much. We really appreciate it.
You're very welcome, and I just want to say a huge thank you for the opportunity and the kind words. And I will go through and I'll read everything in the chat here from everybody that attended today. Thank you so much for attending and listening to me, and I hope it was meaningful and engaging and valuable for you, and that you got something out of it. And if you have any questions, comments, concerns, please, my email is still on the screen there. Send me an email. I'm happy to get back to you. And I just want to say a huge thank you again to everybody that attended, to AVA and FREDA, Sarah, Jason, and Andrea for having me today and creating this opportunity, and just really grateful to be able to share this work and hopefully stimulate some kind of positive engagement and positive traction and keep the ball moving forward here. And a huge thank you to everybody I get to work with at UBC and AHS and BCHS and all the groups we collaborate with. So thank you so much to everybody. I'm just really grateful that to be given this opportunity to highlight some of the awesome work we've been doing.
And we are so grateful for you and your research partners. So thank you, Rory, so much.
Thank you.
Thank you.